Okay, Assalamualaikum and very good morning. I'm Dr. Mashira, OMOP specialist from Hospital Serdang. Okay, so my today's lecture going to cover on histopathology lab procedures. It's full with technical terms. I hope that you can bear with it and be patient. And I also hope that you can gain some new knowledge. So let's begin. Assalamualaikum warahmatullahi wabarakatuh and very good morning to all participants. I am Dr. Nur Mashira, OMOP specialist from Hospital Serdang. This is going to be our last lecture from today's course, and I'm basically going to talk about what happened to your specimens once it reached our histopathology lab. Let's begin with the definition of histology and histopathology. As this lecture is actually about histopathology lab procedures, so I think it's quite good to start with something basic. So, what is histology? It's actually defined as study of the microscopic details and structures of biological cells and tissues, be it from humans' bodies or animals or plants. So we usually examine a thin slice, or we call a section, of tissues previously prepared using appropriate processes called histological techniques. What about histopathology? We have pathology here. So basically, of course, it's about something related to diseases or abnormalities. So we study the cells or the tissues which actually have been removed from the patients, and of course the tissue samples has to be processed first, prepared and stained in order to make it ready for observation or assessment under the microscope. Before the tissue that you send to us is diagnostically ready for pathological assessment, it has to be prepared into a very thin section, which comprises only one cell thickness. Generally, the processes involved are first, fixing the tissue, and second, hardening and supporting it in a suitable medium so it can be cut into the very thin sections that we need. Usually it's about 2 to 7 micrometer in thickness. Two main techniques that we usually use in the lab. First, paraffin embedded sections technique. This is the most common techniques that we use for almost all of our tissues. Second, frozen sections technique. This one is actually specifically for fresh tissue only. So these are the steps involved in histopathology procedures, basically for paraffin embedded techniques. Once the tissue or the specimen arrive in the lab, it will be registered and assign the lab number first, and then the tissue will be sent to grossing center or grossing station, where the officers or specialists will do the grossing, and then afterwards the step is tissue processing, embedding, sectioning, staining, where we give colors to the slides or to the tissue, and lastly cover slip placement. Here it marks that the slides are ready for distribution to the assigned pathologist. The one that involve the officers or the specialists is only in grossing stage and reporting, and the rest either being completed by automated machines or by the medical lab technologies, or we call MLTs. Let's begin with grossing. Grossing is pathological and medical examination through visible aspects of our eyes. Generally, gross examination precedes microscopic examination, where we first identify the pathological area in the specimen and submit it for further examination under the microscope. For instance, gross examination helps the pathologist to identify the cells or tissues that have lumps that might be possibly cancer or tumor, and later microscopic examination is used to confirm this. So the main purpose of grossing is actually to isolate the area or to choose the area of the tissue that need microscopic examination. Usually for small specimen, we will submit all the tissues given. However, for large specimen, like in surgical resection specimen, we will have to carefully choose the area that is important. What do we do during grossing? First, we have to ensure the identity or whom the specimen is belong to. So we will read out matchmaking the name, the ID number, the source and site of specimens written on the bottle to the requesting form. Next, we will then describe the appearance and if present, any noticeable pathological changes, and afterwards measure the specimen. Lastly, we will arrange or orientate the specimens into the tissue cassette. This picture shows a crossing station where we do our work. This is where the officers or the pathologists going to stand or sit while doing the crossing. Okay, and the MLT is going to sit here and enters the details of the specimens into the computer. This is to show you the basic instrumentation that we use during crossing. This one here is tweezer to hold the specimen, ruler to measure, and scalpel blade, or sometimes we use crossing knife for big specimens to section the tissue into smaller pieces. This one here is tissue cassette, where we place the tissue after crossing for further processing. For large hard tissue specimen, saw or electrical saw is needed to cut the tissue into smaller fragments. Okay, let's see here. I want to show you the safety measure that we take when handling the specimen. Lab numbers that we assign to the specimen will be written on the tissue cassette as well as the patient's name on the side. In cases where the patient has multiple specimens or multiple bottles that were sent from one patient, the lab numbers assigned will be following the clinician's label. For example, if you have bottle A and B, which contain tissues from different sites, the lab numbers will also follow this designation. For instance, OPS 2177A or 77B. This is why when we encounter cases where the information or labels written by you guys on the bottle didn't match with the one written in the requesting form, that will give us headache, and that's also when we are going to start chasing you guys. So please carefully double check all your information written to be tally or matched with between the bottles and the forms. Another important aspect that we need to do during crossing is specimens orientation. For small biopsy specimen that doesn't need orientation from the clinician, we will just submit the specimens as it is, given that we also arrange the specimens in the cassette as per how or on what plane that we're going to see the specimens later. For large specimens, for example, the resection specimens, clinician's input is very important. For instance, let's see the picture of lip resection here. Okay, the specimen should be labeled for the surgical margins as well as the right or the left side, because once we receive the tissue, it doesn't have the magician's eye that can see beyond what we have in our hand. Here, the surgical margins from each lateral side will be inked, the deep margin here as well, and the specimens will be sections into pieces that are going to fit in the cassettes. So this is an example on how we arrange the tissue sections just now. The sections with surgical margins will be placed in different cassettes here and here, and the rest or the middle part of the tissues that contain the tumor can be placed in few other cassettes that fit. And now the tissue specimens is ready for the next stage, which is tissue processing. Before we move to the next stage, let me talk a little bit on hard tissue decalcification, because at times we do receive hard tissue specimens in the form of bone, teeth, and or pathological tissue like odontome or fibrous osseous lesions. So for these hard tissue specimens, we will have another additional step, which is decalcification. It is the process of complete removal of calciums and minerals from the tissue, and it is done to ensure the specimen is soft enough for sectioning stage later. After the calcification, these specimens are treated like routine soft tissue specimens, and all hard tissue, except for enamel, can be studied after decalcification. The duration of this process will depend on the size of the specimens. The larger the specimens, the duration will be longer. And that's why sometimes in cases where we receive both soft and hard tissue specimens, we will produce a report on the soft tissue first, and the hard tissue will be reported later. Now, let's move on to second step in the lab procedures, which is tissue processing. Nowadays, this step is no longer done manually in most centers, but usually completed using an automated tissue processing machines like the one that I show here. The objective of this step is to embed the tissue in a solid medium, which is the paraffin wax, so that it is firm or hard enough to support the tissue, to enable thin sections to be cut, but yet it is soft enough not to damage the knife or the tissue later. It is also to enable the tissue to be infiltrated with paraffin wax. And these are the four stages involved in this step: fixation, dehydration, clearing, and lastly impregnation with the wax. Okay, now the first stage in tissue processing is fixation. Fixation will continue for a few more hours to ensure complete tissue fixation is achieved. The purpose of fixation, as what has been taught to you in the previous lectures, is to prevent autolysis, prevent tissue changes, prepare the tissue for further staining, as well as we want to make sure that the tissues can be as close as to their living state as possible without any loss or rearrangement. Next stage is dehydration, where we remove fixative and water from the tissues and replace them with the dehydrating fluid. Here, the dehydrating fluid that we use is alcohol in ascending concentration manner. We usually start from 70 to 90% to 100%. Next stage is clearing, where we replace the dehydrating fluid with a fluid that is totally miscible with both hydrating fluid and embedding medium. So this fluid, usually xylene, can work well with the alcohol as well as the wax as the embedding medium. And last step is impregnation, where we replace the clearing agent, the xylene, with the embedding medium, usually the paraffin wax. Okay, all this stage might sound as an alien language to you guys, but the one that I want you guys to remember is actually here. This stage is going to take 13 to 15 hours, the longest stage in the lab procedures. And where the MLT usually will run the machine overnight after the office hour. Okay, in the next day, after we take the tissue out from the tissue processing machine, we will bring the tissue to the embedding station. This is where the tissue block is formed by using molten wax. This step allows specimen orientation and secures the specimen in the block of wax for section cutting and storage. This step is critical as correct orientation of the tissue is essential for accurate microscopic evaluation. And these are the examples of tissue blocks formed with the paraffin wax and ready for the next step. Okay, the next step after embedding is sectioning. This step is crucial in producing the thin tissue sections that are going to be placed onto the microscope slides. So the objective of this step is to cut about 4 to 5 or previously, like I said, is 2 to 7 micrometer thick sections from the paraffin blocks. Okay, we will use microtomes, and the sections are cut as a ribbon and will be floated on a water bath maintained at 45 degrees Celsius to stretch the paraffin section. And then these sections will later will be fished by using the microscope glass slide. Okay, I will show you the process of the fishing in the water bath in the next picture. So this is what I meant by putting the ribbons of the sections into the water bath, and this is where we fish the sections using the microscope slides. Now our microscope slide is ready with the tissue section, but it is colorless. If we see the slide now under the microscope, we cannot identify which cells or which structure is which. So that's why we need staining. In this step, staining is where we put contrast or colors into the tissue so it can highlight the features of interest. I will briefly explain the process later. And the routine stain for every tissue specimens in the lab is hematoxylin and eosin, or what we call as HNE, where it gives blue and pink color to the tissue. Sometimes, in cases where we need to see clearly certain features of interest, we will also request for special stains. And this is a list of stains available in the lab. Like I said, the routine stain is hematoxylin and eosin, HNE. It will highlight the nucleus of the cells in blue and other structures like cytoplasms in pink. So as many as 5 shades of pink can be achieved when using eosin, depending on the staining method, fixation, the type of tissues, and etc. And still, there are some drawbacks when we use this type of stain, this HNE stain, as it doesn't really answers all our questions. So in certain cases, we request for special stains. The most common special stain that we use in the lab is periodic acid shift stain, PAS, where it specifically stands for glycogen and other carbohydrates. It is quite useful when we want to see or we want to investigate the presence of fungal organism, for example. A little bit on hematoxylin and eosin. Hematoxylin is a basic dye. So a basic dye usually have affinity for acid structures. That's why it can stain the nucleus part of the cell. And eosin is an acidic dye, so it binds to cytoplasmic structures of the cell and stains pink. As HNE is actually a method of staining that is cheap, quick, and is quite suitable for or amenable for automation. So this is one of the examples of automated staining machine for HNE. Okay, so these are the steps for staining with HNE. You might not want to be concerned with this too much, but just for basic information. So first, the tissue sections, the slides will be immersed in xylene to remove the wax, and afterwards, rehydrate the tissues with descending grades of alcohol, and later bring the tissue sections to water. And then staining with hematoxylin and eosin will start. After it's completed, then dehydrate the tissues with ascending grades of alcohol. And lastly, clearing with xylene. These whole steps usually takes about 1 to 2 hours. But remember, when we have lots of slides to be stained, the time might double up. Okay, now we have come to the last step in paraffin embedded techniques, which is mounting or cover slip placement. After the tissue section has been stained, so the slide is not yet ready. It has to be covered with a thin glass cover slip, mainly to protect the tissue from being scratched and to provide better optical quality when we view the slides under the microscope. And the most important part is we want to preserve the tissue section, the slides, for years to come. How do we do it? We just put some mounting media on the slides and then put the cover slip. It will adhere to the slides. And this is an example of a microscope slide with a tissue section stained and covered with cover slip glass here. It is ready for distribution to the pathologist, and this is the original tissue block. Now this concludes the steps involved in preparing the tissue specimens using paraffin embedded techniques. From the beginning of receiving the tissue up to cover slip placement, minimum time needed is 2 days. The reporting by pathologists will take another day or up to 5 days for simple and straightforward cases, depending on our workload at that time. For cases that need special stains or further investigation with immunohistochemical stain, extra few days are needed and the case will be reported maximum in 14 days. Okay, now let's move on to immunohistochemical staining. Okay, just for basic knowledge, immunohistochemistry, or what we call as IHC staining, is used in histopathology to detect the presence of specific protein marker, which can further assist with accurate classification and diagnosis of difficult cases. It is a complementary staining to routine stain H&E and special stains, and nowadays it has been used as a diagnostic tool to assist in diagnosis, like I said, and it's being used for almost half of a century. We have lots and lots of IHC stains or markers available, which we use accordingly to the differentiations of the cells. In difficult cases, for example, a tumor with unknown diagnosis or unknown type of cells, we have few panels of IHC markers to be utilized, which we request according to the morphological features that we see in the H&E stain slides. The most common markers are, for example, for epithelial cells, cytokeratin or CK. For muscle, desmin or SMA for smooth muscle. Also, we have skeletal muscles, specific for skeletal muscles, myogenin or MyoD1. And then for neural cells, usually S100, the basic panel. And then for hematopoietic cells, for example, in case of lymphoma, this will require a few sets of panels. The basic panels will usually to differentiate between B cells and T cells, lymphocytes, for example. And then if you have plasma cells, we have to request for CD138 or CD79A. And this usually sets of markers that we request. We cannot request it all at once. We have to request it accordingly, panels by panels. So that's why in difficult cases, we need extra more days to report the case. So this is an example of a case where immunohistochemistry staining is quite useful. This tumor here, we know might be an epithelial origin, or we call it as carcinoma. So, but we don't know what type of epithelium or epithelial cells that involved here. So when we stain with CK solvent, it gives strong diffuse positivity. So it confirms that this is actually a glandular in origin. Here is a case of epithelial dysplasia where the areas in this section shows moderate epithelial dysplasia. In this one suspicious area, we were not quite sure whether it's actually a cross-section or a true invasion, because of the severe inflammations kind of mask the appearance of this area. So when we stain with pan-cytokeratin or AE1, AE3, it highlights the tumor, and it also shows that few of the tumor islands already separated and went into the connective tissue. So this is a case of superficially invasive squamous cell carcinoma. Okay, now another examples where we can utilize the IHC. This is a case of spindle cell lesion. We don't know the origins of the types of cells that form this tumor. When we stain the SMA, we just want to see whether it's actually a smooth muscle in origin or not. However, it doesn't pick up, so it's not a smooth muscle tumor, but you can see that the internal control is kind of works well here because it highlights the smooth muscle of vascular channels in the lesion. For IHC staining, we will need another day to complete as the steps and procedures involved are quite tedious and complicated. So for tissue preparation, an unstained slides or unstained sections from the tissue block will be kept in the incubator overnight, usually overnight, under 60 degrees Celsius. And then the sections will be deparaffinized with xylene. And antigen retrieval, usually commonly used heat antigen retrieval, which is with microwave or pressure cooker, where the sections will be immersed in EDTA or citrate buffer solution, and then afterwards blocking with hydrogen peroxidase to block the tissue endogenous peroxidase. And then we incubate the sections with primary antibody, and then secondary antibody, and lastly we stain with the chromogen. This chromogen will highlight the features that we want, and the final step is to counter stain with hematoxylin. Lastly, we have come to the final part of my lecture, which is frozen section. It is not about the ice cream here, but it's actually about providing a rapid report from immediate section taken from the fresh tissue removed from the patient's body. Frozen section is a rapid tissue section where we freeze the tissue with the help of this machine here, cryostat, to provide immediate report of the tissue sample. When do we use frozen section? It is mainly used in certain cases or situations. For example, in a surgical removal of malignant tumor surgery, where rapid diagnosis of the lesion is needed, or when the surgeons want to know the extent of the lesion, or in the cases of where we need to do enzyme immunocytochemistry study, or immunofluorescence study, for example, vesicular lesions, as well as cases that need to stain lipid and certain carbohydrate in the tissue. The advantage of frozen section is it reduces the time of processing to 5 to 10 minutes as compared to 18 hours or 2 days in paraffin embedded techniques. How do we process frozen sections? So we use cryostat, where it is actually an instrument to freeze the tissue and keep it frozen while we cut the sections. Rapid freezing of the tissue sample will convert the water in the tissue into ice, and the firm ice within the tissue acts as embedding medium while we're cutting the tissue. Okay, this picture illustrates how we do frozen sections. Here we freeze the tissue and keep it frozen, and then section it and place it onto the microscope slides. Later we stain the slide with HNE. And all of these steps usually take about 5 to 10 minutes as compared to the routine paraffin wax embedded techniques that will require at least 2 days to complete. We have reached to the end of my presentation. I hope you can get some knowledge regarding what happened to your specimens in the lab and what is the process involved in getting a section of your specimen to be viewed under the light of microscope. As conclusion, I would like to emphasize that minimum 2 to 3 days will be needed to produce a report of a simple and straightforward case or an urgent common case like SCC. However, for cases that require further investigation using special stain or immunohistochemical stain, or for hard tissue that require decalcification, the report will be out maximum in 14 days. Preparing tissue specimens for histopathological examination requires care, skill, and sound procedures, and the procedures themselves are subject to human and material errors, and it is very critical to ensure standard and interpretable sections so that we can produce a sound diagnosis. That's all from my lecture. Here are my references. Thank you very much for your attention. If you have questions, you can type in the chat box. We will answer your questions in the Q&A sessions later. Thank you.
Terima kasih saya ucapkan kepada Dr. Masyira atas ceramah beliau sebentar tadi. So again, kalau peserta-peserta mempunyai soalan, mohon letakkan pada chat box dan universiti akan mengumpul soalan tersebut dan kita akan discuss at this end of the session. Okay, seterusnya kita teruskan dengan pembentangan video kita yang terakhir pada pagi ini. Saya mempersilakan Dr. Khairuddin untuk pembentangan video beliau. Dipersilakan.
Okay. Hi, Assalamualaikum. This is a short video of in terms of what happened to the slides when we receive it. Hopefully you can gain some knowledge on what we are doing in the lab, especially when we receive all your small packages filled with surprises. Dr. Mesh, can you please run the video? Thank you.
Ever wonder what happens to the specimen in the lab? Well, we start here in the histo lab. This is the entrance to our new lab. Quite a nice one. All our specimen will go through here, the receiving counters. The MLTs will register and documented the specimen sent to them. And as you can see, it's quite busy. The MLTs are now doing the registering and also receive some new specimen brought by the PPK. Once registered, the specimen is kept in the specimen room. The dental specimen will be placed in a red holding trays with designated numbers. What happened next is the grossing process. The grossing process starts at the grossing station. It is referred to as a cut-up, which involve careful macroscopic examination and description of the specimen that includes appearance, numbers of pieces, and the dimension. For smaller specimen, the entire specimen will be processed, while the larger ones may require further dissection to produce representative pieces from appropriate area and multiple samples may be taken. The tissue then will be placed in a cassette before being loaded to a tissue processor. The remaining specimen will be stored in the storage room before they are properly discarded later on. Now the MLT is loading a basket of cassette for overnight tissue processing. The next step is the embedding process. Here, one of our MLTs is preparing the cut specimen for the embedding process. It is done on the embedding console. Specimen were removed from the cassette and the wax mold is prepared. The biopsy specimen must be aligned properly in the wax block. Finally, it is filled with wax. And after that, the specimen block is now allowed to solidify on a cold surface, and when set, the mold is removed. For the sectioning process, we need a microtome. It is a specialized precision cutting instrument. It accurately and repeatedly slices section of a wax block. The block specimen is placed and cut on a precision instrument using extremely fine steel blade. The MLT is doing the sectioning process now. The paraffin section usually cut at thickness of 3 to 5 microns, ensuring only a single layer of cells. Then, as sections are cut, they will stick together edge to edge, forming a ribbon of section for easier handling. Fishing. A paraffin section being mounted on a microscope slide after being floated out on warm water to flatten them. Now is the drying process. After the drying process, the slides are ready for staining. Staining allows for differentiation of nuclear and cytoplasmic component of cells as well as the intercellular structure of the tissue. Standard stain in surgical pathology is hematoxylin, which is blue, and eosin, which is pink. You can see here a rack of paraffin section being loaded onto the automated stainer for H&E staining process. The process begins here. The process is fully automated. Then the next step is the cover slipper process. Here, the MLTs are loading all the slides in a special rack on the cover slipper machine. Fully automated also. As you can see on your right hand side, the robotic arm is applying specialized glue on top of the stain microscope, microscope slides, then followed by placement of the thin layers of cover slippers. Let it dry for a few minutes. Once the slide dried, it will be placed on the rack on the left hand side. This process will be repeated onto a new slide. So it's a well coordinated process. So see the last slide. There, see, the last slide has been mounted on the rack. Now the process is finished. Now the microscope slide as cover slippers on top of it. Here we can see the difference between the slides with cover slippers and without cover slippers. Cover slipper will give a good optical quality for viewing under the microscope. Now the MLTs are sorting and labeling the microscope slides. After that, it will be arranged in the microscope book and sent to the designated pathologist for examination. What do we see under the microscope? On your right hand side is an example of H&E slides, which is blue and pink. And for difficult cases, usually the pathologists will get together and do some serious discussion. And lastly, this is our unit in SDH.
Alright, thank you Dr. Khairuddin. Okay, so alright, lagi sekali ya, kalau ada soalan sila letak di chat box, nanti kita akan discuss at the end of the session. Okay, so sekarang ni just a quick reminder, dekat chat box tu ada link untuk attendance. Untuk attendance hari ni ya, so sila klik pada link itu dan tuliskan nama penuh dan fill in the form lah, and then click submit. And also another link being shared is the feedback form. So boleh klik pada link itu dan isi feedback form tu juga ya. Alright. Okay, so sekarang kita akan teruskan dengan sesi Q&A. Okay, soalan pertama kita adalah sebentar ya, kita akan share the soalan. Boleh nampak ya? Kalau siapa tak nampak, sila maklumkan kat chat box ya.
Okay.
Okay, saya bacakan soalannya. Nanti para penceramah boleh slip in and answer lah. Okay, so the first question is from Dr. Tam Hui Ling. I think this one is from the first lecture today. Where can we get or download the lampiran A form? I think saya serahkan kepada Dr. Fairuz lah.
Okay. Okay, I'm not sure about the Sarawak lah, but lampiran A, maybe I can maybe you can ask Dr. Charlene. Lampiran A ada kat Sarawak ke tak? Because lampiran A ni we use in Sabah kan. Okay, and we already distribute to all clinic lah. You can ask from your SDO or maybe your YM lah. Okay.
For Sarawak, we don't have lampiran A.
Okay.
The speaker tu kena on. Alright, for Sarawak, we don't have lampiran A. I think what Fairuz meant for lampiran A is basically information regarding where and who is sending the specimen. Am I correct, Fairuz?
Yeah.
Yes? I can see it's noted.
Yes, right. Yeah.
So for Sarawak, we don't actually have lampiran A because lampiran A is not standard. Lampiran A is more of up to the facility who is doing providing the service. Now, the most important form is your per pack form, your laboratory form. That is the most important form. Please use that form and don't use any other forms which is outdated. Use the latest one because the lab will only receive that form. All right. For per pack form, you can get it from the lab itself. any lab that is providing laboratory services. So you can take it from the lab that's providing blood tests and things like that. It's the same form. We use the same form. All right. So I hope that answers Dr. Tam.
Yeah.
Dr. Tam is from Sarawak,
Oh,
Sri Aman. So
okay.
your platform, you can get it from the lab at Hospital Sri Aman, and we don't have a lampiran A. All right.
Okay.
Okay. So back to Fairuz.
Okay, for the participant from Sabah, we need a lampiran A because last time, because in our perpet, it
Thank you, Dr.
doesn't ask
Faris
for
dan Dr.
the.
Noor. Okay, untuk
Hello?
dah
Okay, tak dengar?
oh, okay.
Boleh? Boleh dengar saya ke? Sorry. Maybe orang tak clear. Hello? Okay.
Sorry. Okay, soalan saya daripada Dr. Gabriel Chai. Soalan ni mungkin daripada video pertama dengan ceramah nombor 4. I would like to know more about taking suspected pemphigus and pemphigoid lesions as biopsy specimens. Would you prefer fresh tissue, Michelle's or formalin fix, or we should ideally transport both, or are there any oral lesions indicated for DIF?
Okay. Okay. I try to answer it. I answer the second question first lah. Okay. Are there any other oral lesion that are indicated for DIF kan? So DIF is a technique that we use in our lab kan. Used for apa? Diagnose disease that from kidney and kidney, skin, and also other organ lah kan. Usually we use it to diagnose something that suspect or autoimmune disease, connective tissue disease, or vasculitis lah. But for our side, usually we use it for blistering disease lah, vesicular lesion kan, vesicular lesion. Okay, pemphigus, pemphigoid itulah. Okay, other than that, sometimes we use for lichen planus as well, but jarang lah. Okay. So if we suspect pemphigus and pemphigoid, okay, we need both. Okay, the tissue from formalin fix and also fresh tissue. Okay, fresh tissue. Usually we ask the operator to take a adequate amount of tissue, and then you divide two. Okay, half you put in the mixture solution, and another half you should put in the formalin. Okay, because the formalin one, we want to see whether the tissue is enough or not lah. Okay, because the one in the IF, we just see the staining, we don't see the tissue. Okay, I think that's answer your question.
Okay, thank you, Dr. Fairuz. Is there anyone else who wants to
Maybe Dr. Liu want to add? Okay,
sorry. Yeah. Hello.
Ah.
Yeah. So in addition to Dr. Fairuz's answer, so I think basically for lesions like pemphigus and pemphigoid, the formalin fixed tissue is the basic one that we need.
Yeah.
Because from H&E sometimes like most of the time, if the biopsy is done correctly, and then we can get specific HPE findings saying that this could be pemphigus or pemphigoid. The DIF is like adjunct diagnostic tool, because sometimes DIF is not that accurate that we can see the antibody deposited nicely. So sometimes we cannot see anything at all. Yeah. So you must have formalin fix, and then if you have the facilities or that you can do DIF, then it will be better. Yeah. DIF is just to correlate with the HB, the H&E findings. Yeah.
How about Sarawak later, Dr. Shalin?
All right. I think okay. Now answering Dr. Gabriel's question. Yes, for all specimens, the standard is using H&E staining, which is you fix formalin fix, yeah. But so if your tissue procurement is good for pemphigus and pemphigoid, we are able to see that split and demonstrate it nicely. So we are very confident. But sometimes because your tissue procurement due to certain techniques, the epithelium has fragmented and things like that, we can't demonstrate all the features of pemphigus or pemphigoid. So it becomes a little bit difficult. Now, DIF is an adjunctive procedure. If we can have both, it's the ideal, I would say. All right. Now, but you must also ask the center before you send for DIF whether the centers accept DIF or not. Because for direct immunofluorescence, the technique is different, and you actually need a different you need a microscope that is in a darkened room. You need a different type of microscope for it. It's not your normal microscope. You cannot view like your normal H&E staining. All right. So your lab might not offer that service, so you might not be able to send to that lab. So you actually need to get in touch with the pathologist whether they offer that DIF technique. Okay. Now, your other question is whether any other. Yeah, no. there's tak apa. I cannot see. There's a chat box keluar. Whether we other lesions that is indicated for DIF. Now, DIF is mostly we do it for pemphigus and pemphigoid, but you can also do for linear IgA, you may need a DIF as well, but these are all vesiculobullous. Sometimes there may be histological, what do you call it, a dilemma in a lichen planus. You can do DIF for lichen planus because it has a specific pattern to it as well. All right, but you said whether we prefer fresh or formalin fix. So whether we prefer one or the other, but to me, I think if you want to send for DIF, you should also send for H&E. H&E is just a standard. DIF is the second part. So you need to send actually for both if the lab accepts it. All right. I hope that answers your question. Virus, is that okay?
Yes, the protocol here, they must send both.
Yeah.
Yeah, because they want to assess the tissue lah, whether it's adequate or not. So they need one in the formalin as well for H&E. Okay.
Because there may be some problems. I mean, when it comes to transportation to a different place, you may have problems at transportation. So if you send only one, you might not. If you encounter any problem, then you don't have a backup for that one. All right.
Oh yeah. Oh yeah. Another thing to add, they should consult us lah, because for blistering disease, usually we ask officer to take from the pre-lesional tissue instead of the lesional tissue.
Yes.
So
Yes. That's true. Yeah, that's why I think for if you are thinking of vesiculobullous, if you're not sure, then it's best to consult before you actually do the biopsy, because you'll be repeating the biopsies later on if it's not done properly. All right, because there's often you may encounter some problems while you are taking the biopsies and things like that. Okay. All right. So question 3.
okay.
Question 3, three from the Justin link. 3 layers packaging required for samples sent from nearby clinics. Faros or Liu?
Okay.
Nak jawab?
Yeah, sure. Can we do that? Okay. For the 3 layer, okay. For the nearby clinics, so no need lah, because sample that transport by hand, 2 layers should be enough lah. Okay, because the one who transport usually know what is it in the packaging kan. So for those from other center or other daerah which require passing from hand to hand, we need a 3 layers lah. Okay, packaging. Okay, is it right, Dr. Shalin? Oh, maybe yeah, Dr. Liu.
Oh yeah, because I am thinking if like by hand, for example, in Sabah, like they want to send from OS to here, so we'll advise they put the specimen in the biohazard bag, right? And then in the rigid container, for example, an ice box or a big plastic container. You don't really hold the bag to us lah. Then send it properly in that way. Then it will be better.
Oh yeah, and get it covered.
Uh,
Because it is supposed to.
I think that standard is everywhere. So well, the 3-layer is a little bit different in that one because you don't need all the absorbable plastics. The plastics that you buy, and you're not sending it by post, by air, or by another transport, but you are the one who is sending it by land transport. Then the bottle is a must, and then the second layer will be we put inside biohazard plastic bag. Okay, now even in the hospital itself, from the clinic, if we send to the lab, it has to be in a container like this. Can you see? Oh no.
Yeah. You're right.
a rigid container.
Rigid container. Yeah.
Plastik macam ni. Okay, you can't be walking around bringing the specimen just like this in your hand in a plastic. And you get something like this, store it in a storage box like this, and you carry it to the lab. All right. So I hope. I think there's another.
So Dr. Shalin, that's considered 3 layers so lah kan? So they need.
Yeah. Consider lah, but not quite with the material and everything like that. But for if you are transporting through air or even by bus, I think you need that absorbent material in between, because if there is any leakage of formalin, it will be absorbed by this material. We had one case last year. Yeah, we had very bad leakage. It was sent by post. It wasn't packed. The seal was tight, and so there was leakage of formalin. It was sent by air. So formalin was everywhere. It leaked up onto the box itself, the outer box. The post laju refused to send it to us because it was just reeking of formalin. So you must remember, when we send tissue sample, especially by flight, we actually have to conform to the ACTA. There's an act that we have to follow. If not, then it's going to cause problems for us. Kita dah langgar ACTA tu. So you really need to pack properly. You're sending by flight with proper packaging and some absorbent material. Make sure that the formalin does not leak up from the bottle. All right. And don't send big specimens in plastic bags, only in plastic bags with lots and lots of formalin in it, because that will definitely leak up. It has to be inside this impervious bottle, properly sealed, so that it doesn't leak up from there. Right? Okay. Last question from Dr. Tan. Okay, betul Cyrus? Ada lagi? Tambah?
No, I think okay. I think you answered Dr. Justin Ling question lah. But for from our jiran kata OS kan, so that one should be okay lah kan?
Yeah. It is next door. You don't really the full packing up, but make sure that when you transport to the lab, all the bottles are transported to the lab in, you just carry it in a container lah, yang bertutup. Sebab that's most hospitals, that is the SOP lah. Yeah.
Okay.
Right.
I think the last question.
I think, the last question sounds like my question. All right. Before we move on to the last question, I think you asked me about probably just a brief mention on COVID positive specimen, yeah, virus.
Oh yeah, thank you. Yeah, maybe you have any idea because the one that I share, it's not a protocol, it's just based on breeding. Yeah? So I think I just
I think
take.
the the SOP, it seems to differ in different places. There are some similarities in the protocol SOP in Sarawak and SGH for COVID positive cases. All right. Now those from up within the hospital itself, they will actually have to call the lab and inform the lab that they're going to send a COVID positive specimen. And normally they will only accept at 4 o'clock. All right. The earliest they accept is 4 o'clock because that's when everything, most of the things that's in the lab, the process has completed. So they accept it when everything's almost finished at the end of the day. But it's from an outside clinic elsewhere, then they would like the specimen again triple packed, and this time it must be in the ice chest box, sealed and labeled COVID. All right. So when they receive that, yes, it will be disinfected and they will store it in one place, and they will only process that either once a week or once in 2 weeks. Now I asked the lab here, why is that so? One is because they nak jimat PPE, but also to make sure that the specimen is really fully fixed. Yeah, because for large cases, large specimens, the formalin might not have entered right at the center of the specimen. So you need the whole entire specimen to fully fix. Now, the advice from the general pathologist, the anatomic pathologist as well is, if there's a very large specimen, to actually make a cut in the specimen, but the specimen afterwards must be wrapped in gauze, all right? And the gauze is put at where you already made that cut. That is to maintain so that the tissue will not get distorted. So you need to wrap it up in gauze. Then you put in formalin. So you need a lot of formalin for that because you already put gauze. All right. So that's one way to make sure that the center is fully fixed for COVID specimen.
So Dr. Shalid, in that case, better hold the biopsy first lah, kan? Because
yes. If non-urgent, it's best to hold the biopsy.
sebab
Right? Because
you have
they will not
one.
the biopsy.
Yeah. In Sabah, usually we stop for 3 days only later before we process lah. That's different lab, different SOP, right?
Yes.
Yeah.
But it's very similar lah, along the same line, I would say. Okay, now the last question 4. I think this is more to what I presented yesterday, but the question was only submitted today. If I have dental officers interested to attach his OP or M, are there any minimum requirements from specialists themselves and department for the particular dental officers, such as any professional papers? Because there are certain specialist departments in certain states advise division to encourage those who are interested to take up at least professional papers. All right, now for Dr. Tam, since you are from Sarawak, I just like to inform you, especially those in Sarawak. Currently, we have a working group. We just established a working group last week. We are finalizing the guidelines for officers who are interested to do attachment with a certain specialist. All right. So there are, yes, for those who have some professional papers or have passed exams, they are, of course, would be given a priority, but it is also dependent on whether the specialist would accept you or not as well. Okay, not everyone would have, but we can still accept those without papers, but we would like to encourage them while they're doing the attachment, they sit for this professional exams. Okay, but I can't share with you all the details at the moment because we have not finalized it. So for Sarawak, we have a proper criteria some general criteria, some specific criteria, and we are coming up with a proper format of application. So there is a special program, and how long you can be attached as well. There is a set time period as well, and that is all in the guidelines. The guidelines will be shared, I think, with all the DDOs later on once it's finalized. At the moment, it's still in that working stage. All right. But if anyone who's interested, I think in my lecture yesterday, I said you can approach any of the specialists nearest to your center at the moment. All right. For those in Sarawak for OPOM, Kuching is the only center that has OPOM services. So I hope I've answered Dr. Tam's question. You want to add, Fairuz, for your side?
Okay. I think for Sabah, we just follow what the TPCAN lah kan. There's a requirement for those who want to attach in kepakaran kan. Okay, but Doctor, so far we just recognize few places for master program kan, like UM and Australia and Otago kan, the new one kan. So maybe the professional paper that they can take BMS or maybe freckle kan.
Yeah, depends lah. But I think now we are encouraging them to do more locally lah, rather than overseas. So, but the scholarship is limited. Usually there's only about 2 a year, or sometimes we even don't have it on a yearly basis. So, but you should try, and because you should show an interest. It's not like, oh, I would like to do an attachment here because I do not want to work in the periphery. I want to go back to a bigger town and that's the only place I can do to get out. That should not be the mentality here. You should do an attachment because you want to do an attachment and because you are interested to do the specialty. Again, yesterday I said that the main criteria for those who want to do an attachment with OPOM is interest, interest, and interest. So the 3 criteria are just interest, interest, and interest. All right?
Right.
Main criteria, if I was. All right? Because, okay. All right. Sorry, I got to go.
Okay. I think there's no more question, Dr. Zar.
All right, I think that's the end of the question session because there's no more question from other people. Okay. Okay, saya bagi masa 2 minit macam semalam. Siapa-siapa lagi yang nak tambah soalan boleh letak kat chat box dulu ya. 2 minit.
Hi, I'm back. So sorry. Some urgent matters that I have to leave for a while. Right. We are reaching almost the end of our workshop here. Looks like we're finishing early. There are some people who's already left. Okay. Now, before you leave, can you fill your attendances and also fill the feedback form? So I hope that you all gain something from this workshop and you at least have a better understanding of what we do, basically, especially oral pathology, because I think most of you don't really know what are the lab procedures that's being carried out, why certain things take much longer time to be reported. All right. Now, we will be sharing your the lectures in a PDF format later on. This will be emailed to you. Now, all your questions will be put into an FAQ. You need a seven. Okay. But we've also prepared some questions for FAQ, standard questions that you might find useful later on. All right. So, ada ramai dah left. Alright, ada yang dah left. Okay, so I think that's about it. So, Sabam? Saya kena pergi punya penutup. Oh, ni dah ada habis dah. Macam mana dulu? Okay, oh apparently I'm supposed to be bagi ucapan penutup. Ni lah ucapan penutup saya. So, I hope, yeah. Yes, I hope you guys have enjoyed it and it helps you in your daily work from now. Okay, so I would like to thank everyone who's involved in this workshop. All right, Dr. Sabam and Dr. Fairuz, who are the penyelaras for Sabah and Sarawak, all the speakers, those two, Dr. Liu, Dr. Mesh, and Dr. K for the videos. Would like to thank Zarif for helping us out with a lot of the administrative work that's involved. Okay, all right. So hope to see you guys in another workshop. If anything, you can email to us. We will try and answer that. All right. So thank you very much. Have a nice day. Bye-bye. Fairuz, ada apa nak cakap? Oh, by the way, we should thank Dr. Fairuz for that wonderful video.
Thank you, Dr. Shalin.
So Fairuz, say something. Amesh? Sabam. Oh, by the way, for those of you who are still here, we will try. Sekejap Jangan keluar dulu. Siapa yang masih